detector in a capton and get always reproducible depths of measurement 70 micron, which required by protocol for skin dosimetry. It's extremely interesting development. When you take this detector in your hand, you can't see detector embedded in a plastic film capton. So we develop reader. We develop now wireless reader, and I just would like to show you a couple applications with this detector. The detector is disposable. So for example, one of the important applications which we are doing is high dose rate brachytherapy. And particularly we're using ultrasound truss probe for planning and treatment simultaneously. In this case, we can put detectors on a surface of the truss probe. We know actually position of detectors on a truss probe. It means we know position of detector relative to anatomy. And it allows us to control skin dose on the rectum wall during the HDR treatment. So you can see on this picture, we can see, for example, 4 or 3 detectors, and we can see in real time what happens when source dwelling from one catheter to another catheter. And we can evaluate actually what happens after each catheter, in each particular dose on the surface of rectum. So you can see here, it's a software which allows you to see half-growing dose in 4 points where detectors is after each catheter. You can see wireless reader here, which wirelessly delivering dose to computer. It's very convenient, it's battery operated reader. Battery now allow for 40 hours non-stop walking. And currently we introduce this technology in Milan Cancer Care Center, in United States, and it's St. George Cancer Care Center. You can see here, for example, truss probe with 4 detectors placed in this probe with a condom, and you can see ultrasound image of prostate and detector, 4 detectors on the surface of rectum wall. You can see source dwelling here, and we can see after each catheter, it's example of 1 detector only, what is the dose planning should be in this point and what dose we're getting. And finally, you can see we can deliver with accuracy 0.2%. So this technology allows us to change philosophy of HDR treatment. And currently, instead of 2 and 3 fractions, we're using only 1 fraction, which is economically beneficial because we have clear understanding what we're delivering in real time. And if something wrong, we can stop radiation. So it's extremely important. It's approved. It came through ASIC approval, through TGA approval, and this instrument currently under commercialization with company Electrogenics Laboratory. So we will be happy to introduce in your practice this instrument and share our experience. So these detectors we are using in different applications, gynecological application, in multi-way collimator to measure dose on the rectum during the treatment. We're using in a rectum balloon for mobilization prostate and to get dose measurement on a anterior rectum wall. So it's very convenient, it's disposable detector and always reproducible, doesn't matter in odd, it's out of 1,000 detectors, you have 70 micron plus minus 5% depth of dose measurement. Another interesting application, we're using these detectors in interventional radiology where doses can be quite high. So all of you familiar certainly with the different procedures in interventional radiology, particularly neuroangiography, coronary angiography, and other applications. So what is the advantage of such kind of developed detector? Detector is invisible. You can see here 2 metal clips and detector, more skin, but on the imager you can see only clip. Detector you can't see in comparison with other detectors, which actually always interfere field of view. And this we're considering quite big advantage what we achieved. And currently the detectors people using in many procedures in interventional radiology to measure dose on the skin of back or a measure dose on the eye during the procedures. So you can see here two detectors on the eye, but you can't see detectors on the image here. And you can see in real time, this is a procedure 600 seconds, and you can see in real time how changing dose for different kind of procedures, DSA, road mapping, sign trace, or fluoroscopy. And then you're getting report. Based on this report, you can see where you done mistake, or you have to increase procedure to make sure that dose to the patient will be minimum. It's excellent tool for training young physicians, which we implemented currently in Australia. Another interesting development is the Medipix detectors. We developed system gamma camera in the rectum. So you can see pinhole gamma camera here based on 3 Medipix detectors. Each detector has resolution 50 micron, and each detector can measure spectrum of X-ray radiation. So you have 56 channel, 56,000 channel, and 56,000 MCA, which provides spectroscopy for each pixel. It's amazing detector, which we currently develop system for measurement of seeds implanted in low dose rate brachytherapy. So with this system, you can see position of the seeds in a registered ultrasound image, and you can compare what planned position. You can see blue, it's what you determine, and red, what was planned. Here you can see prostate, you can see urethra here, and physician can see in front of him in process of implantation what kind of mistake he done, and system can in real time reconstruct and advise where to put next seed to compensate mistake. It's very interesting development. So it's allow you to use ultrasound probe to do planning, and then to put gamma camera in rectum, and you can see how to, after each seed, position of the seed. Additionally, we've implemented this in high dose rate brachytherapy. You can see how source moving, and you can compare with real actually position, which actually treatment planning system advice should be in this case. It's very interesting development, and currently also under commercialization. You can look our paper if you will be interested. Name of the BrachyView technology. It's published a lot of papers currently. So I would like just discuss a little bit about external X-ray radiation therapy, what we're doing here. An interesting development, so named Magic Plate. So it seems to be very familiar to dimensional distribution of diet, but system very interesting. We're using similar approach like in Moss-Skin dosimetry, where we're able to produce embedment of small silicon detectors in a capton. And it became like a piece of paper with the detectors, and electronic outside of this capton. So totally it's thickness of about 0.35 millimeters, 0.4 millimeters. And currently we produce 1,987 pixels simultaneously read out with temporal resolution 100 microsecond. So you can see each pulse in LINAC, and currently is a 30 by 30 centimeters, quite nice development. What is the advantage of this device? You can use in transmission mode. When you put in transmission mode, it's absolutely do not perturbate beam, because thickness is 0.35 millimeter of capton, and do not increase skin dose like for other devices like Delta and the Dolphin detectors. You're getting increasing dose, skin dose 0.1% only, and penetration transmission 99.8% of beam. So you can use this system in a phantom and different depths. So it's multifunctional system. And particular, if we're talking about application in transmission mode, like you can see here, you can see in real time opening of multi-leaf collimator, and you can compare with treatment planning system immediately. And in parallel, you're getting fluence. So you can calculate in real time in vivo dose in the patient using beam model. And system extremely light. Currently it's wireless system, and currently also under commercialization with company Electrogenics. So we're capable in our center to develop not only detectors, we're developing all instruments. It's development software, it's development hardware, it's clinical testing, implementation, and everything done by PhD students. So in our center, we try to develop skill of people, to develop new instrumentation, not just to use well-developed treatment planning system. We're developing ourselves. We're doing Monte Carlo calculation, we're doing technology detectors, we're implementing clinically, we're commercializing these detectors and system. Another interesting development which I would like to share with you is small field dosimetry. Certainly as well familiar in stereotactic radiation therapy and stereotactic body radiation therapy, we're dealing with very high doses, especially currently when we're talking about decreasing number of fraction and hyperfractionation, where in spinal cord, like treatment, doses can be 25, 27 gray single treatment. Mistake, 0.5 millimeter, 1 millimeter can lead to serious complications. So with complication of techniques, requirement for quality assurance became more and more serious, especially in terms of spatial temporal resolution. We know a lot of methods have to deliver accurately stereotactic radiation therapy. We know frameless, high precision imaging guidance radiation therapy, a lot of software developed, but currently, unfortunately, we do not have system which allow you to get very high spatial resolution in real time resolution and without corrections. So we spent a lot of time to develop such kind of system, especially more complication coming if you're talking about motion adaptive radiation therapy, when we're using target which target moving like lung, and you need to make sure that multi-leaf collimators also moving in the same way. So we developed so-named motion adaptive radiation therapy using dynamic multi-leaf collimators. And I would like a little bit discuss about this with you currently, which require very complicated quality assurance, require movable detectors which moving exactly like a tumor and to see how system can work. But if you're talking about small field dosimetry, you have challenges here. First of all, it's lateral disequilibrium. Secondly, it's steep dose gradient. And additionally on top, motion, if you're talking about motion adaptive radiation therapy. In terms of detectors, it produces big problem. So you need to have small sensitive volume, but if you're getting small sensitive volume, you automatically getting small signal. So you need to have very sensitive system in terms of readout. You need to have pixelated detectors and small pitch between them, but it's leading to another problem. You have too many channels and you would like to have high spatial resolution with like 500, 600, 700 channel. It's another challenge. You need to have high temporal resolution because you would like to measure each pulse. So within 1-2 milliseconds, you need to measure 1,000 channel. It's another problem. And you need to have real-time operation. So what we've achieved here, I would like just to show you. All detectors which currently exist in the market, the beautiful detectors and Delta 4 and two-dimensional array and ArcCheck and Octavus, but unfortunately for small field dosimetry, not all of them ideal, especially if you're talking about 10 millimeter field, 5 millimeter field, 15 millimeter field, it's not easy, especially when you're talking about brain treatment. We're using still GovChromic film. It provides you two orthogonal direction, but you need 24 hours to wait when GovChromic film will be ready for readout. So what we develop? We develop so-named magic plate, or we can call them monolithic magic plate, where silicon detector size about 55 by 55 or a 75 by 75 millimeter, which specifically dedicated for small field dosimetry. You can see here 4 different types of detector. One dimensional, it's a linear array with resolution 200 micron. You have 2-dimensional 512 pixel with resolution 2 millimeter. You have, we call this M5, deliver duo detector with two orthogonal array of sensor with resolution 0.2 millimeters, and we have octa detector with 8 diagonal linear array with resolution 0.32 millimeter between pixel, and each pixel 40 by 800 micron. So it's very sophisticated detector and very sophisticated electronics, which allow to read out everywhere here 512 channel in each detector. And I would like just to show you application of this detector currently. First of all, we'll talk about treatment of lung tumors. So we have a movable lung target. What we achieved, we developed dynamic multi-leaf collimator, which capable to follow tumor. Additionally to required opening like stationary target, we have another vector which moving multi-leaf collimator synchronically with tumor. So you can see here on this picture a temporal pattern of particular patient, specific patient for particular lung tumor. You can see in Y direction, tumor is moving quite a lot, about 2.5, 3 centimeters, but in X direction, it's not so much in lung. So what we're doing, we're using Calypso system, which is tracking tumor using electromagnetic sensor. You're familiar certainly with Calypso system. And Calypso system provides signal to multi-leaf collimator, which following to tumor. The question is, how do you know that they're following correctly? This is the reason why we develop these detectors, which can move like a tumor. I just would like explain what we're doing here. First of all, static radiation, no problem. Tumor is stationary, you can deliver quite accurately dose. However, if you're not doing motion tracking and you're moving tumor, you're getting blurring of dose, and unfortunately, margin should be very large. When you're doing tracking and motion, you're doing much more accurate, but it's even here exists problem because unfortunately, multi-leaf collimator is a mechanical system, and tumor has quite high acceleration at the end when tumor start to move back, and mechanical system can't afford such acceleration. So you need to have so-named motion tracking prediction. So you need to learn how tumor is moving first 30 seconds, and then to use algorithm which predicting position of tumor. So how to verify this? What kind of quality assurance you can bring here? So you can see here our detector, particular M512 in a phantom. You can see Calypso system here, and Calypso transponder beacons here, electromagnetic, which provide signal to Calypso, which provide signal to multi-leaf collimator feedback. You can see here detector plane and phantom, which can provide 6 degrees of motion, exactly the same like a lung. So you can see here motion of phantom with a detector 55 by 55 millimeter, 512 channel, each pixel 0.2 by 0.2 millimeter, and 2 millimeter pitch between pixel. So phantom driven by real temporal pattern of particular patient, and each patient can be, pattern of each patient can be used to verify treatment before treatment of patient. You can see electronic here readout. It's quite interesting to develop. Currently, it's wireless electronic. And you can see what happens here, 1 by 1 centimeter field. You can see how it's dose blurring if you're not doing motion tracking. However, on this picture, you can see again the same motion, 1 by 1 centimeter field, and detector is moving like a lung, but no blurring. It doesn't matter. It's the same like stationary. And this is what you can see happens when you're doing motion tracking. So you can see here expected profile for stationary, and red one, if we do not have motion tracking, you produce huge mistake, 60–70% in dose. But with motion tracking, with dynamic multi-leaf collimator, you can see how nice agreement. You have about 3–4% on the edges only. And this is impossible to verify without any kind of devices, unless you're using chromic films and 24 hours to wait. But now it's working in real time without any problem, and you're getting immediately result in terms of how accurately performing your treatment planning system and how effectively performing Calypso system in dynamic multi-leaf collimator. So it's a very interesting development. You can see here motion without tracking, with passive tracking and predictive tracking. Predictive tracking is even better. You can see how beam adjusting to the motion of tumor here. Very interesting development. Now it's available and become ready to implement clinically. So it was done on many patients, with different kind of pattern of lung motion. And we can see average 85% improvement in dose delivery and huge saving of normal tissue here. So we introduce even special parameter, what is the area and the difference between motion tracking, no motion tracking, as an advantage of motion tracking. However, it's not for each patient. For some patient, it's not so good result because patient sometimes nervous and pattern changing and not always ideally. Still big benefit in comparison no tracking, but not the same like for most patients. So we need to admit it's very individual to patient as well. So for this part, I would like to conclude that M512 is a high spatial and temporal resolution tool for characterizing motion tracking algorithm in real-time adaptive radiation therapy. The result independently verifies the MLC tracking is capable of mitigating some of the effect of patient motion during treatment. So we're getting about 85% improvement. Effectiveness of tracking system is heavily dependent on the type of motion experienced. This is exactly what I mentioned you, that some patient, it's not so big benefit, like not 85%, it can be 60%, 70% improvement. So stereotactic radiation therapy, verification of cone, dose from cones. So it's another problem. Currently people using a lot of scanning diode, or people using chromic film, which is not extremely nice and not so useful in busy clinics. So again, we develop detector. You can remember duo detector with 2 orthogonal pixel with a 0.2 millimeter special resolution, where you can get immediately profile of beam. You can see 5 millimeter cone. We're getting within 5-second profile, and it's beautiful agreement with chromic film. The same for 10 millimeter cone, 25 millimeter cone, 40 millimeter cone. So it's implemented clinically now, and people quite happy with this instrumentation, which allow you daily QA for cones. Another interesting development is the octa detector, which I mentioned you, for small field dosimetry. So certainly, in some situation, we need resolution better than 2 millimeter. So on the other hand, we would like to have such resolution through whole field, which unfortunately not so easy because you're dealing with 1,000 channel electronics. So what we've done, we developed detector with a 512 pixel, but which getting 8 array. You can see here 45 degree, 105 degree, 90 degree, and 0 degree, and pitch 0.32 millimeter. So it's intermediate benefit between duo detector, which only 2 axes, and M512 detector, and resolution good, and number of and coverage also quite nice. I just would like to show you application of this detector for output factor verification for small field. We developed these detectors in such packaging special, which do not require any correction. Most detector in small field dosimetry, as you remember, in diamond detector, stereotactic radiation therapy detector, PTW, and some nuclear, they require some correction. This detector immediately measuring profile and measuring N output factor with the central pixel and do not require correction. Also is applicable in FFF field. So we're quite happy with this development. You can see here fields from 5 millimeter up to 50 millimeter, comparison with micro diamond and ionization chamber. Ionization chamber can measure 5 millimeter field, and we're getting brilliant agreement with micro diamond, but without any corrections which required for micro diamond. You can see for 10 megavoltage field, for 6 megavoltage field, it's extremely interesting development. We're getting within 1.5% agreement without any correction. So it's very useful for verification in CyberKnife, particular iris collimator, which I would like to show you. You can see on this picture 5 millimeter diameter and 7.5 millimeter diameter profile provided by iris collimator. And you can see comparison on the right side with CRC diode from PTW, which sort of gold standard for such kind of profile verification. And again, we're getting beautiful agreement, but we don't need to use point by point to scan in a water tank. We're using this immediately. And plus, these detectors are tissue equivalent. It's no problem. You can see comparison depth dose curve for this detector as a function, comparison with Monte Carlo simulation. Particularly, it was done for 60 millimeter diameter of opening iris collimator. So we introduced new domain of small field dosimetry with magic plate. We call them monolithic magic plate. And currently we develop detector 75 by 75 millimeter with 987 channel with resolution 1 millimeter in the center and 2 millimeter outside. So it's a beautiful detector which currently under investigation in MRI LINAC. And additionally, we developed detectors which are MRI compatible. It's no any artifacts, and they working nicely in magnetic field up to 3 Tesla, which I will show you as well. So in Australia, currently we're developing MRI LINAC, which allow you treatment in direction along the magnetic field and perpendicular magnetic fields. It's a big development with Sydney University, Wollongong University, led by Professor Paul Kiel, my colleague. And such kind of development demand quality assurance in magnetic field to make sure that detectors suitable for magnetic field and detector working fast and not interfere by magnetic field and electromagnetic field. So I don't need to convince you why we're doing MRI LINAC. We would like to see much better resolution of soft tissue, and we would like to treat and see simultaneously deformation and adjust treatment online. But you need detector for verification of this. So currently we organize special testing facility in Illawarra Cancer Care Center in Wollongong. We developed magnet 1.2 Tesla permanent magnet, which allow you to placement detectors and to measure with magnetic field and without magnetic field. So well known that magnetic field, unfortunately, changing profile of the beam. You can see here blue is a profile of 1 centimeter field without magnetic field, but when you put magnetic field, you're changing penumbra and not any more symmetrical distribution. But detectors which we develop here, two-dimensional, do not using any material ferromagnetic like nickel, and they're beautifully working and in full agreement with Gauss-chromic film. You can see here detector profile, what we're measuring in field 1.2 Tesla. You see, it's not symmetrical, but it's exactly the same like measured by Gauss-chromic film, but demand 24 hours for obtaining result. But here we're getting result in real time and immediately. So now it's implemented in practice in Electa, LINAC, MRI LINAC, and we're working with this detector. So interesting development which we're working now is the particle therapy, because as you know, Australia going to have in 3 years proton therapy. In India, you have already proton therapy, and you have, I think, heavy ion therapy as well, carbon-12 therapy. We're working a lot in this direction many years, in particular for verification RBE in proton therapy and heavy ion therapy. I don't need to convince you how good is a particle therapy. All of us know Professor Bragg, who was born in Australia, Australian scientist who actually come up with the idea Bragg peak, which allow us to deliver dose in depth and minimize dose in the entrance. So, but however, this kind of therapy quite complicated, especially if you're talking about heavy ion therapy, even on a level of nucleus. Let's consider cube 10 by 10 by 10 micron. If you radiate with the gamma radiation, like X-ray radiation, you produce quite uniform, sparse radiation. However, for the same dose, you need only several ions, and those in track structure changing 10 to the 5 times within 2 microns. It's leading to absolutely different damage of tissue and different radiobiology, especially when you're changing energy. For example, low carbon ions, you need even 6, 7 ions to deliver dose. So the question is, what to do this? In this case, we need talking about microdosimetry. So we're talking about stochastic deposition of energy, not anymore deterministic absorbed dose, but stochastic. In this case, we need to understand event by event what energy will be deposited in each cell on a cellular level. And this is the reason why we introduce concept of microdosimetry in particle therapy in terms of development detectors. The major parameter in particle therapy is linear energy. It's energy imparted to the cells in single event divided by average chord of sensitive volume, which usually we're considering sphere, about 5, 7, like 10 micron, depends on cells. And what we're doing in microdosimetry, we're measuring distribution of linear energies. And based on distribution of linear energies, it's not LET. Linear energy is not LET because LET is impossible to measure. It's a pure theoretical concept. But here we're talking about regional microdosimetry. Not all delta electrons actually stay in the cells. Some of them outside. And this is what actually happens in a cell. So in this case, you can introduce RBE. So what does mean RBE? If you are considering 2 survival curves of cell, one of them for X-ray black one, and another, for example, for protons or a heavy ion blue one. And we are considering 10% survival cells. The ratio of doses, dose of low energy, low validity radiation to dose high validity radiation, provide you so name RBE 10. And beauty of microdosimetry kinetic model that it's allow you in linear quadratic model alpha described through linear energy, or more accurately dose average linear energy, which you can measure with a microdosimeter. So it's allow you to predict without cell experiment what actually RBE will expect. And I will show you how important this is in proton therapy and heavy ion therapy. So people used to use microdosimeters, big tissue and proportional counter. However, with such microdosimeters, you can't do in stereotactic, or you can't do in proton therapy or heavy ion, anything. So what we done, we developed chip, silicon chip, which based on 1,000 cells, silicon cells, which modeling biological cells, the micron size, spherical and cylindrical diode. So its advantage of this detector is because you're modeling simultaneously group of cells. And size of natural You don't need to worry about gas. You don't need to worry about 1000 voltage. You don't need gas balloon. And it's very small and portable chip. And I would like just to show you simply, we don't have time, but some aspect of this application. So you can see it was patented, such kind of array of cylindrical volume. And this what was developed. You can see detector fragment, just rectangular cells, 20 by 20 by 10 micron, which produces so named silicon insulator. And each cell, it's respond to radiation. You can see scanning alpha particle beam. You can see have good charge collection. And recently we developed cylindrical, which very close to sphere. It's amazing technology, so named three-dimensional detector technology. Each detector 18 micron by 10 micron, 10 micron by 10 micron. So it's a cylindrical PN junction detector. And you can see
Professor Rosenfeld, sorry to interrupt. Professor Rosenfeld, sorry to interrupt. You have only 3 more minutes
yes,
for
I'm
your presentation.
Now. Yes, yeah. Thank you very much.
Yeah.
So we developed a lot of these detectors, interesting. They can provide you RBE in heavy ion therapy. You can see spread out break peak, how RBE changing. Beautiful agreement with tissue proportional counter. We're doing a lot of collaboration with NIRS, HIMAC in Japan. 3 times per year, we're going there for measurement in heavy ion therapy, many students involved. And particularly, it's very important for proton therapy. In proton therapy, in radiobiological system treatment planning, now we introduce linear energy dose average, which actually allow you to improve treatment. So it was done a lot of experiment for survival curves as a function of LETD. People try to understand how to take LETD to make sure you can predict survival cells. And very interesting work of Paganetti, which demonstrated you can consider additional dose with a coefficient K times LETD, which equivalent to additional dose, which related to increasing RBE. So you need to measure in treatment planning system LETD. So we developed such detectors, and currently we demonstrated that we can measure dose average linear energy, which increasing essentially at the distal part of break peak, which not actually correctly to use 1.1 RBE in proton therapy. We demonstrated you need to use 1.7 last 5-6 millimeter. Currently, it's implemented in practice, and in Groningen Proton Therapy Center, we introduce new quality assurance, RBE in proton therapy. So we done, for example, this in a beautiful experiment in a phantom. You can see anthropomorphic phantom. We done planning of microdosimeter. We deliver pencil scanning beam. You can see our microdosimeter, very portable probe. And we can measure LETD distribution and compare with RACE treatment planning system, which predicting this LETD. And we can get very nice agreement. We can see particular for nasopharynx plan in water. And finally, we can see this additional dose which should be implemented to patient. And again, it's a beautiful agreement with treatment planning system. So if you take into account RBE in proton therapy, you need to physical dose, which is about 200 centigrade. To get another dose, it's about 50 centigrade here. So it's getting much higher dose and absolutely different treatment. So it's introduced now in clinics. It's patented and commercialized currently. It's another interesting development that you can read in the paper. So just to mention, last slide, we train about 14 people who work now in proton therapy. One of them, director of MGH in Boston, Ben Classy, technical director of proton therapy. Tipois Nicholas, in charge of treatment planning in MGH. Scott Penfield, in charge of proton therapy in Adelaide. So many people, and Andrew Rowe in Loma Linda Proton Therapy Center. So we'll be happy to help you if you're interested in particle therapy and introduce our instrumentation, which we are going to work currently with your colleagues here. So CMRP is very nicely linked to many countries. We have collaboration with many centers, and I hope we can get with India as well very soon. And finally, I would like to invite you in our biannual meeting, Micro Mini Nano Dosimetry and Innovation Technology Radiation Oncology, which will be in Noosa, Queensland, a nice place, in 1.5 years. Hopefully, COVID will be okay. And thank you very much for your attention. Any questions, we'll be very happy to address.
Thank you, Professor Rosenfeld. There are a couple of questions. First one would be, what would be the energy dependence of Morskin dosimeter in kV range, and what would be the difference when we compare it with ionization chamber response?
Okay, the major advantage of Morskin detector, you can measure skin dose on a depth 70 micron reproducibly. Do not exist any detector which can measure skin dose unless you will put film, and film require long time of for processing. Okay, and all detectors reproducible, as you remember, it's required to measure depth 0.07 millimeter.
Oh.
And they're disposable detector. You put in the garbage, you don't need to worry about them. And currently will be wireless for patient on the skin 5, 6, 7. You can put them, and they don't need even power. They like TLD, but measuring skin dose and immediately.
Okay, and one more question, Professor. What is the life of the semiconductor devices, like dose saturation? What would be the limit of dose saturation with your detector?
It is a good question. For example, for Morskin, this is not a question because they're disposable. The opposite working on radiation damage. But if you're talking about diet, they tolerate 10 megarad, megacentigrade, 10 megacentigrade. You can measure 10 years, 8 years, but you need certainly verify each year to look what is if any damage to compensate. But usually you're doing the pre-radiation, and after pre-radiation, they're very stable. Even in neutron field, we demonstrated 18 megavoltage Linac when neutrons exist as well. So 10 megarad.
Yeah. Thank you, Professor. And one more question is that what is this? What is the spatial resolution of motion tracking?
Spatial resolution motion tracking. So we're done with two types of detector currently with DUO and M512, 0.2 millimeter in DUO detectors. In M512, it's a 1.5 millimeter.
Oh, very nice, very nice. Okay, okay.
So we can from 0.2 dependently what detector you're using. And Octa is 0.32 millimeters.
Okay,
it's interesting
Professor.
development. Interesting development.
Okay, okay, Professor. Nice, thank you. And Professor Rosenfeld, it's really astonishing to know the various detectors developed in your center, and a wide application of your devices from brachytherapy to all modalities of teletherapy, and even in proton and heavy ion applications. It's really wonderful work what you do. And we are very much happy to have you. Thank you for giving the wonderful lecture to our AMPI community. And we thank you once again, Professor Rosenfeld. Thank you very much.
Thank you very much, Dr. Ganesh. And just to mention that Medipix detector for microdosimetry awarded the best paper of the year, Medical Physics 2018. Last year. So it was nice recognition of development detector for proton therapy.
Oh.
Best
nice,
paper
Professor.
of the year.
Yeah. Nice, Professor. Thank you. Thank you very much.
Thank you very much. Thank you. I will stop sharing my screen, and please send me email, and you're welcome to come.
Sure. We wish to have you. We will be happy to have you in our conference next year, Professor. Thank you. Thank you for your acceptance. Thank you, Professor.
Send student for master program.
Thank you.
Yeah.
Thank you. Thank you. Thank you, Professor Anatoly, for a very elaborate and informative talk. Thank you, Dr. Ganesh.
Thank you. Thank you very much.
Thank you. I now invite our next speaker, Dr. Devakumar. will be talking on uncertainty in tumor delineation, relevance, solution, and application in radiomics. Dr. Devakumar.
Yes.
I would like, I would like to invite the I would like to invite the moderator for this talk, Professor G.S. Pant. Professor Pant.
Yeah, Dr. Anuj.
Professor Pant is around?
Yeah.
Yeah.
Dr.
I invite Dr. Anuj Tyagi, Joint Secretary, AMPI, who will introduce Professor Pant.
Thank you, Dr. Sawab. Welcome all the participants for IDMP. I have to introduce the moderator of the next session, Professor G.S. Pant. He is retired professor from All India Institute of Medical Sciences, New Delhi, after serving the 27 years around. And he has experience in the PET-CT installation, 2 PET-CT installations over there. And thank you, Professor G.S. Pant, sir, for joining us. And I hand over to Professor G.S. Pant to moderate the next session. Thank you.
Thank you so much. It is my pleasure to introduce Dr. Dev Kumar, whom I know for many years. Dr. Dev Kumar has been working as Associate Professor in the Department of Nuclear Medicine at Christian Medical College, Vellore. He worked on surgical simulations and molecular imaging at Thomas Jefferson University, Philadelphia, as a postdoctoral fellow during 2008 and 2010. He developed a software module which is used in neurosurgery and radiation oncology department at CMC for segmentation of pituitary adenomas and head and neck cancers. He is the technical head of Imaging Information Technology Division, that is the PACS, of the CMC hospital since 2013. I remember vividly when I visited CMC that about 15 years ago, he showed me how the PACS they are going to design. Happy to know today that he is heading that facility. His current interest is on the development of prognostic and predictive models for cancer patients. Today, Dr. Dev Kumar is going to speak on radionics and radiomics, which is what is the relevance and what is the workflow that he is going to speak today. I hand it over to Dr. Dev Kumar.
Good evening. First of all, I thank Dr. G.S. Pant for the kind introduction. He is always very helpful to me, and he is always very good to me. So I thank him very much. And I also thank Dr. S.D. Sharma, Dr. Shobha Jayaprakash, Dr. Henry Finlay Godson for giving this opportunity to present this work or to talk on this area to this AMPI community.
You can switch your camera off.
So hope you are able to hear my
on. And during the presentations, everybody may keep the mic off, so audio off. Okay.
Hey, madam, we have not heard from Georgia, and Georgia is here.
She was
I think we're getting some disturbance.
Hello.
I think.
Good to see you. Hello, Ibrahim.
Yeah, I think you can mute everybody.
Somebody has not unmuted.
Madan, we had a very good FOM IDMP celebration.
Hello, can I continue?
Yeah. So carry on.
Okay.
Therefore, please go ahead.
Okay. Good evening, participants once again. Okay. This is about radiomics. So mostly I will be focusing on the relevance and the workflow. So I would like to start with the objective of the radiomics. That is, it is a prognostic marker that is irrespective of the therapy. That is like whatever therapy you give, and then how they are going to respond. That is the prognostic biomarker. And the second one is the predictive biomarker. That is predicting the therapy response. So this is a little different from like commonly what we do, like you give the therapy and then you find out whether it is responding or not. Instead of that, I would say this is before giving the therapy, then we can develop a biomarker which can predict whether the therapy uh, will be useful or the patient will respond to that therapy or not. So the mostly, so this is the two areas we are going to focus on. So I would call this area as a biomarker discovery. So this is the area we are working on. So even though we call it as radiomics. Radiomics is a broad area, but the application or the focus or the usefulness of radiomics is on this biomarker discovery. So this slide, I'll 1 minute. I'll try to annotate. Okay, 1 minute. Yeah. So um, okay. So here actually I would draw a line. So this is we can say the radiomics feature extraction area. So I will take you through these steps, and then the next area we should know about this radiomics is this part, which is actually the machine learning and development of prediction model. And then, so basically, when most of the work is on these areas. So when we complete this area, actually the biomarker development is completed. So we have a biomarker. So maybe we can say that that is a biomarker. So basically, when we say biomarker, it can be a prediction model. And then that prediction model or this biomarker is for a particular um, purpose, maybe like to find out the therapy response of a particular therapy, or to find out a subgroup or something like that. So then when the patient comes, then you do the imaging and then get the radiomics features and then feed it into this model, and then you will get then you will get a decision support, like whether the therapy can be given or not, the patient will respond or not. So this is coming under the area of treatment personalization. So this is all about the whole radiomics workflow. So here this can be repeated any number of times. So whenever the patient comes, and then this process will be repeated, and then we need not repeat this process when the patient comes. So this is once you have to finish this, and then we can use it for 10 years or 20 years till you get a better biomarker. So this is the workflow. So I would like to introduce the features that is in the microscopic scale. So it's not exactly the radiomics features I am introducing. It is the features generally in common I am trying to introduce here. So if you put a picture like a histopathology slide of adenocarcinoma lung, so what you can notice is that loosely organized cells in this picture, and then so we can call it as a feature. So we can give a name for that feature called a structure. Then what is the value of that feature is loosely organized. So we try to identify features in this. So I'm just again repeating it. So the name of the feature is structure, and then the value for that is loosely organized. So if you put another picture like this is a squamous cell carcinoma lung histopathology slide, and then what you notice here is dense internal structure. So here the name of the feature is not changing; it is the same name structure. So what is the value for that feature? Uh, that is dense. So the name of the feature is same, but the value is changed. So the previous one is quite loose, and then this one is actually dense. So definitely with the cancer to cancer, or like different type of cancer, there is a difference. When we look at the histopathology slide, or when you look at the cell level, there is so much of difference, and that feature is very obvious. Okay, so can we get it in imaging? Like when the level of resolution what we are working in, like imaging in hospital, uh, are we able to get it? So this is one example, but it's not a clinical image. This is actually basically a DTA MRI, and then using a fractional anisotropy map. But here what they did is they took the entire tumor and then used it for histopathology. So they sliced it and then used it, and they got the histopathology image here. And then the same sample as a whole, this image is as a whole, the DTA is done, and then the corresponding slice is taken, and then maybe this registration is done. So you can see, maybe you got the bottom one you can focus on here. Things are marked, and then we are exactly identify the same regions in both. So so in preclinical level, not in clinical level, preclinical level, we can find a similarity between the imaging and the histopathology. So do we have to always have this one? So for example, another one here is actually some features we can see. For example, so these are the features. So some shape difference. So this type of features can we see all the time? So that is a question. And then another question is it enough? If you see these shape differences, and is it enough to convert that into a biomarker or develop a biomarker out of this feature? So in BIRATS categorization, I think this is quite common. So they look at, radiologists look at this type of features. So uh, the question is like, these features are adequate? Is it enough to develop a biomarker? And second question is, can we see this type of features in all the imaging we do? Like for example, if you do a CT scan, can we see all these features? So there are two questions to be answered. So we'll see when we go through the rest of the talk. So this is the question: do you have to see to believe? So better to see. If you can see, it is always good. So you do a imaging, CT scan or MRI or whatever imaging you do, and then if you can see a lot of features, even inside the tumor, if you can see a lot of heterogeneity, if you are able to see, it is always good. That is one thing. And then when you develop a model based on the feature extracted from them, and then most likely it will work. Then there is other side also, like for example, if you are not able to see, and then we need not be so discouraged that we cannot develop a model, we cannot extract features, or even if you extract features, it won't be useful. So that is also not true, but we have to be very careful in that, so that because we cannot, the third important thing is like we cannot also think that we need not, even if you don't see anything, and then if you do a very coarse imaging like 5 thick slice thickness or very low MAS. So even if you do some imaging with very low quality, we can get a lot of features and we can develop a biomarker, successful biomarker. That is also not true. So we have to be very careful in going through this field or getting into this area of biomarker discovery using this radiomics. So because of that, all that very concerning, very important questions we have in this field, I'll start with the acquisition. So here, maybe, okay, so I'll start with the right side here. For example, you do a CT scan and then or the same object or subject, and then you repeat after some 1 hour, and then how many features we are able to reproduce. So some features, if you are not able to reproduce in the test retest, and then that they are not good features, so we can ignore that features. That is a quite important thing. And then, for example, this is the intra-CT. So here, the important things are KVP and sorry, KVP and MAS. So when we change these features, what will happen? So then the third thing is like, for example, multi-center biomarker development or multi-center use of biomarker. If you are involved in, then this is quite important. So we should have a proper fandom and then standardize the image acquisition between different CT scanners. This type of fandoms we can use, and then you do imaging, and then you get some ROI like this, and then get the features, and then analyze how it is useful. So here, the important thing I want to highlight here is actually the reproducible features are quite less. For example, when you change the tube voltage from 80 to 140, only 43.2% of features are reproducible. Okay, so the rest of them are maybe like around 60% of the features are not reproducible. So that to be very careful. That means like when you play with, when you change this thing. So if you develop a biomarker on particular energy, and then you cannot just change when you use it, when you apply that biomarker for individualized therapy. So the other important thing is like reconstruction kernels, and then you get only 43.1 reproducible. So you have to be very careful in standardizing this image acquisition. Okay, so there's another phantom we can use, like this is cadence cartridge radiomics phantom. Then there are some methods researchers suggested. There is you can use the same image, patient image itself, as a calibration. Like you can draw a background here and then maybe another background here, or actually one background is enough. So depends on which organ you are working on. So use that as a calibration, self calibration basically, or it is called as an internal calibration. So this is also quite useful. And we can design there are some phantoms available, and or we can design some phantoms with multiple features or multiple materials, and then you can use that to analyze how the variables are, how the features are. So the important things here is a control protocol can reduce total variability by 50%. So the what is important is this controlled protocol. That is very important. So that is why they are recommending this control protocol should be used for radiomic studies. So another important thing is like most of this benefit can be obtained from reconstruction, extra reconstruction. so which doesn't add any dose to the patient. Okay, so I'm now taking you to the radiomics workflow. So here actually, what biomarker you want? Actually, maybe like before, I think we have to spend a lot of time in this area. Like, so what you want to do in your center? Like, which area is very important to your clinicians? Like, you want to develop a for example, you are starting a new therapy, or some group of patients are not doing well for some therapy, and then you want to find out a biomarker to find out which is a subgroup of patients who can benefit from that therapy. So that type of questions you have to formulate, and then get this target variable, and then you choose like you are going to use CT, MR, or PET, or you want to be going to use all of them. So that modalities also you have to decide. So you can use a combined all the three modalities or more modalities you can use. And then standardization, like I explained now, you can use the standardization of image acquisition, and then you establish the pre-processing, and then you find out how much data you have. So if you are having like thousands of patients, and then like segmenting each patient data, maybe like if it is a CT, MR, there are so many slices, and then can you segment all of them manually? So what are you going to do? Or going to use some automatic segmentation or something like that, or you can go through this pathway, like deep learning pathway, something like that. So most of the focus today is on this area, like then you extract the features, and then you select the feature. That is very important, feature selection, and then model training. Then you validate the model. So this model, what you got is the biomarker actually. So then you are done with the biomarker development. Then you can start like after the validation, after the proper validation, and then if you get a good result in the validation, then you can start using it for the clinical purpose, and then you can take it to the bench to like a bench to bedside. You can take it to the clinical side. So this is similar one, and then I just trying to show another branch so this is the image you get, and then you take it to this they call it as a convolutional neural network. And then here the advantage is actually you are not doing any segmentation. Like for example, if you go in this path, so you have to do a segmentation, whether it is automatic or fully automatic or semi-automatic or manual. Some segmentation is involved, a lot of manual thing, and then so many steps are there, like I said earlier, feature extraction, feature selection, all that. But if you go through this path, actually, like you need not do any of that. Actually, you need not do even segmentation. You need not extract manually any features, and then rearranging all that you need not do. So this is another path. Okay, we can call it as a deep learning path. Okay, but today's focus is mainly on the top portion. Actually, mostly we'll be focusing on this one. So definitely we cannot cover, if you go into this, we cannot see that adequately. So I'm skipping this part today. So segmentation is so we'll be going through each step here. And so first maybe segmentation, then feature extraction, then feature selection, something like that will go. So one by one I will be taking you. So first is segmentation. So some aspects of this segmentation I'll try to introduce. The So for example, any like for example PET scan or a CT scan, if you take, and then when you display it, then you set a intensity for that, and then for example, if you set some very high intensity, then you may not even this part actually you may not be able to see. You may see only this part and this part. Sorry, only this part and this part. And then CT scan. Suppose if you set a intensity, like for example the windowing, so if you change the window, and then the image will look different. And also the preset windows what we see are not, it's arbitrary basically. like we cannot say that it is always correct. So when you change the intensity or threshold, window threshold, and then it will be look different. So suppose if you set the threshold as 30%, then the tumor will look so big like this. So, but if you set the intensity to 70%, then it may look so small like this. So which is true. So we may not know. So we did a study and then we published in 2014. So we call that as adaptive threshold, and then this is focused on pituitary adenoma and then using PET. So some of the fandom we developed locally, and then we designed that, and then we collected the data, and then we set the threshold. So this is the threshold values. So we set the threshold, and then the correlation coefficient is 0.99. So then we get this machine learning algorithm, not the algorithm, not the machine learning model. So this model, we used it on retrospective clinical data, and then we got a correlation of 0.94. So the same model, the same machine learning model we used for segmenting head and neck cancers also. So it goes like starting with 25%, and then it will create a 3D shell. That is this shell around the tumor, and then so this internal portion and then the external portion, they calculate the energy, and then depends on the energy the tumor segmentation grows. And then finally you get this final segmentation like what I'm showing here. So we also developed another algorithm. Like actually, this is quite common algorithm everywhere. Most of the image processing softwares will have this one, but then we modified it. The reason is actually this GROKET is having a lot of uncertainty because depends on how you draw the background and target regions. The tumor volume changes actually. So much of uncertainty. So to reduce uncertainty, we developed one, and then we called it as improved GROKET actually, and then you can see how it performs. So yeah, so this is the IGC is the that blue color one is the one, and then so the advantages are actually zero uncertainty, no manual intervention. So we need not even draw foreground and background labels actually. So this is the the module, the software module which we used for all the segmentation. So it is having a initial setup, and then we can choose whether we going to work on PET CT or MRI, and then all the other things I explained earlier. Then we can get, and also it will give some statistics like the SUV max in that, and then SUV mean in that, and then volume also, and also like TLG if it is a PET, all that. So and then this is the segmentation actually we get from that actually. Then we can export it to other radiomics softwares, or we can, suppose if you want to, if you are using it for some research in radiotherapy, we can export this segmentation. So the other area is actually persist and resist. This we can say this is a feature, or we can independently use as a model also. But a lot of studies showing that this model we develop, if this is independently used as a model, it may not be doing very good like the models we develop from the full radiomics features. So this is the front end, but this is not a big software, but the whole thing we developed in Excel, and then we can enter all the values, and then it will give the final classification. So whether, for example, this case it is a partial metabolic response, and then how much is the reduction in SUV, then how many weeks from the therapy, and then is there any new metastasis or not. So this classification is like, so we can say that independently this is a classification model, because it can classify it as a partial metabolic response or complete metabolic response, stable disease or progressive disease, all that it can classify. So we can even call it as a independent model or biomarker. But suppose if you want to use it as a feature also, you can use it as a feature. Then you can feed this into other models along with radiomics and then get a better model actually. So we did a small study with this many patients actually. So this is a total number of there is a total number of patients here, and then we used the resist and then how it is classifying, and then you look at there's so much of variation. We used persist, and then it is, for example, this is a complete response, and then this is complete metabolic response. So this is 26 and this is 7, so much of variation. So resist and persist doesn't go well. So but scopy and resist is almost equal, like 27 and 26, but the persist is not at all going along with that. Okay, so then these are the whole thing. What I have shown earlier is the first part of the workflow, that is a segmentation. But that is actually, we can say, like uh, sort of semi-automatic segmentation, because even though we developed the full sort of we did not draw background or foreground, all that. But we have to identify the tumor, like where is the tumor is, like you have to put a dot and then you have to show the tumor, then it will start from there. But here, actually, people have developed some better segmentation algorithms. This is a deep learning based algorithm. So you just give the image and then it will give the segmentation actually. So, for example, if you look at this case, it is the dissimilarity coefficient is 0.95, very good correlation with the manual segmentation. So this type of fully automated segmentation also you can use. Okay, so that's all about segmentation actually. Then now I want to jump into this feature extraction. Okay, so within that segmented area, then for example, you take an image like this, like 4 by 4 image, and then you look at for example, I'm showing only one feature here, like that is called as a gray level co-occurrence matrix. So here this is looking at, like for example, it is 0, and then in how many places it occurred along with that actually. So for example, so then you plot it like this is for 0, that means like how many times 0 and 0 occurred together, like that is this 2 times actually. So you mark it as 2 here. And then maybe I think I cannot go each one, and for example here, how many times how many times 2 occurred continuously. So then we can say that as 3 here actually. Okay, so like that you can create a new GLCM matrix, or we can even we can even call it as a GLCM image. So this is the original image on the left, and then this is the GLCM image on the right. So like that we can create images. And then originally this was developed in 1970 by Geological Survey. And then you see that the GLCM map, so wherever this built up area is there, the houses, so wherever the houses are there, and then it is nicely identifying that. I'm showing this just to show that, like, the meaning, what is the meaning of this, like what is GLCM, and then what are the applications. Then yeah, so this is not a new area. Radiomics is a new area that came in 2012. We can say it started in 2012, but um, like this feature extraction and then this texture mapping was started in 1973 itself, and then it is having very very useful applications in other areas actually. So like I showed the houses pattern, like we can show for the pet images also here, like for example, the same GLCM, if you show here, then it will look like that actually. Okay, so different features, if you show, it will look differently. So then this is all intensity or histogram based features, and we can put an image like that actually. Okay, but actually, like this is just to show you. I am no putting this slide, but actually for biomarker development we won't be using these images, but we will get from that image we will develop or will calculate another features like derived features. So these are actually called as the features. So the important thing you have to notice is this is from the same image, GLCM. So this is not the actual image. So actual patient image will take, and then we'll calculate GLCM image. And then from GLCM image, we'll calculate all these features. So many features we can calculate. So the important thing is actually this is a single value actually. So this is not an image, and then you get a single value, and then this single value represents the entire tumor what you segmented. Okay, so however area you segment, and then this is representing, these numbers are representing the characteristics of that segmented area. Okay, so now actually when we extract these features, we get around like 400 features, and then it is like, for example, so what are we going to do with these features? So like I said, we have to develop a biomarker. What is that biomarker? It is a mathematical model. So so basically it's a mathematical equation with like 400 variables. So like here one small example is like if you develop a mathematical model with the 400 variables, what will happen? So look at the bottom one here. This is one overfitting. So this is what happens actually when you increase the degree or terms of the polynomial. Like I think all most of the time you would have encountered in Excel sheet, when you try to fit some points like this, you get some experimental data and then try to fit it, and then increase this degree, and then you will get well fitted one. Like it will be going through each points, but actually it is a overfitting. So this is not at all good actually. So this is what happens when we have so many variables, like 400 variables. So what we have to do is like we have to get some good fit like this. So here actually, so like here this degree is only 2, and then when we have a degree is 7, and then this what happens. So we have to throw away a lot of unwanted features. So it is a big job now. That area is called as a feature selection actually. So here, for example, the features can be classified like this: histogram metrics, shape features, texture features, filtered features. So we can classify like that. So here maybe we can use some wavelet transform or something like that. We can get the features. Okay, then you look for the stability, like whether like to test retest, and then what are the features stands there, and then you choose them. Otherwise you ignore that features, and then you look for variance. For example, if you have some um, pre-therapy, post-therapy, or different time points, and then what are the variants, and then choose which is showing good variants, and then ignore features which are not showing variants. And then correlation, like you, for example, they are correlated, and then that means like both variables are showing trying to tell the same thing. So we don't need both variables, so you can ignore one of that actually. Okay, then there are some other techniques also called as a minimum redundancy, maximum relevance, and then RFE, like that actually. So so the whole this slide is all about feature selection. So what you have to notice is like here you have so many features, and then here you end up with a few features, and then you use only these features for biomarker development or mathematical model development. So maybe I'll skip that. And so this is one of the technique people use actually. This is called as a correlation cluster. So you, and there are some mathematics behind that, and then you can go through some tutorials, and then you can do that. So it is not just a correlation matrix. You can get easily the correlation matrix. You can basically like each feature, you can get the correlation matrix with the other features, and then that is basically a Pearson correlation coefficient. You can calculate that Pearson correlation coefficient and then put it in a matrix, and then in MATLAB you can plot it. So then you will get a correlation matrix. But here little more it's done here. Actually this is called as a hierarchical, agglomerative, clustering is also done on this one. So it groups features like this. For example, this is one group, and then this is another group, and then this is a third group, and then fourth group. 1, 2, 3, 4, 5, and then 6. Okay, so so this one, now we got 6 clusters. Instead of all the features, and then now we got 6 clusters, and then what we have to do is from each cluster you have to choose only one feature. So basically we'll end up with only 6 features actually. So I skipped this one because always this diagonal will be correlated, because usually you are that is a correlation coefficient is always 1, because the same feature, diagonal features are same features. So one feature you correlate with the same feature, it is always 1, so we cannot consider that actually. Okay, so you got 6 clusters, and then you choose one feature from each cluster. Okay, so that's what here actually 6 clusters, and then you get one feature from each cluster. So that's what we get. Okay, so this type of okay, so what we did, we also did in our center one feasibility study on head and neck cancer. So what we tried to do is we tried to predict local failure after radiotherapy. So otherwise, like in machine learning terminology, what we can say is we try to develop a classifier, and then what it will classify into responders and not responders actually. So this is what we are trying to do. And then so all the feature selection methods I told earlier in the another slide we used, and then at the end we used another algorithm called like machine learning algorithm called lasso. So then we thought, okay, why can't we use lasso alone, and then what will be the difference? So basically like two methodologies, and then which methodology is good, like that we try to compare. Maybe I'll take you through this lasso, and another one called as this is a little bit modification of lasso, that is a ridge. um, so like for example, these are the two training data set points, and then you try to fit with this red line. So usually it is a well fit, but the problem is actually so much of bias involved in this one. So when you have so much of bias, and then when you go into the testing data set, like the testing data points may be somewhere here, and then so when you fit it, actually the line will be here, but then we are going to use this one. So the problem is actually then we will get so for example, the data points are here, and then this is the what to say is, okay, this is the square distance. So the square distance will be very high, and then because of that, what we can say is variance will be very high here. Okay, so to reduce the variance, so what we can do is like we can have a little bit of bias. So that is obtained by, so usually least squares method actually, no, this is a common method we use for fitting any data actually, but then here this is also added to that, and then this is called as a regularization term. And then the important thing you have to notice is that slope curve, and then this is a lambda value. Okay, so this is basically a regression model, but added with the regularization. Okay, um, maybe okay. So the whole thing, when we do this, actually we have to estimate this lambda value. So how do you estimate? That is one method called as cross validation. Okay, so that is quite important to calculate this lambda.
Exactly.
So, so you change the lambda, increase the lambda value, and then the coefficients. So the coefficients changes, like so many coefficients. Otherwise we can say like coefficients of many variables will tend to 0. so it will fall into 0. So that means we are ignoring many variables can be ignored or not selected. So the advantage is like Lasso is having a built-in feature selection method
Dr.
actually.
Dev Kumar, you can now wind up. I think the time is, you can take another 1 or 2 minutes.
Okay, thank you. Okay, so okay, so this is the results of that. Our algorithm, what we, the mathematical model we developed, and then that is actually like AUC is 0.73 for Lasso, and then if it is a ridge, and then it is a 0.79. So what we can say is the ridge is doing little more better actually. So what I can say is like, okay, this is how we can develop a biomarker, and then maybe this is a model we get, and then we can uh, do it on like this is also validated, and then maybe we can validate on a bigger group, and then if this is doing well, then we can use it as a biomarker in clinical situation. Okay, so maybe I can wind up like that. Okay, thank you.
Thank you, Dr. Dev Kumar. Thank you so much for your nice presentation. I think there is one question for you. How much collaboration is required to perform such kind of research? What are the professionals involved in such kind of research activities? What are the available uh, open source databases to learn these skills? What is your opinion about national? I think this I wanted, I also wanted to ask you this question. Uh, what I feel is that Dr. Dev Kumar, you are a wonderful worker. I know that. So, but in India, particularly in nuclear medicine, there are very few physicists who can do the modeling. So I suggest that you organize a workshop of only 4 or 5 people from the country, then who can learn this technique and use at their centers. It is extremely required in nuclear medicine. The modeling is required. People starve for this, then they get something from here and there, use it. So therefore, I suggest that you should do it because people should learn from you because you are excellent worker on this, but only you, you are very silent worker. So please advertise it, make organize a small workshop, maybe for a week, and where you can have access to them, the PC, and train them on this. Then periodically they can connect with you on online and learn from you later. I think this is my opinion because I am out of profession now. But because your skills should be you utilized in across the country in nuclear medicine. I know that because few centers I know they very badly need people who can develop some model for them. So thank you very much for your wonderful presentation. I also thank Dr. S.D. Sharma to invite such an excellent worker and to drag me to drag me uh, to this platform. Thank you very much.
Thank you, sir. I agree with your valuable suggestions. I'll definitely try to arrange some workshop. So I definitely have to agree with you on arranging this type of workshops. Thank you, sir.
Thank you very much.
Thank you, Dr. Dev Kumar. Thank you, Professor Pan, sir.
Thank you.
It's my pleasure to invite Professor Mahesh, who will be talking on CT dosimetry and optimization. Dr. Mahesh. Okay. I invite Dr. Ajay Srivastava, who will be the moderator for this talk.
Thank you,
I
madam.
request Dr. Sridhar Sahu, the Treasurer AMPI, to introduce Dr. Ajay Srivastava.
Yeah,
Dr. Sridhar.
Good evening, madam.
Good evening.
Yeah, good evening, ladies and gentlemen. It is my great pleasure to introduce Dr. Ajay Srivastava. Dr. Srivastava is currently working as Chief Physicist cum Radiation Safety Officer at at the University College of Medical Sciences, University of Delhi. He has written one book on medical imaging technology and contributed 27 chapters in 8 other books. He has about 20 research papers in national and international journals. He has been involved in conducting lectures for MSc Medical Physics program for 3 years at the University of Peradeniya, Sri Lanka. Over to Dr. Ajay Srivastava.
Thank you, sir. Thank you for a nice introduction. And very good evening to all participants. Thank you for being with us today to celebrate IDMP 2020, organized by our association, AMPI. I am honored and privileged to moderate the last session, very interesting, very informative session on CT dosimetry and optimization. This is going to be talked by Dr. Mahadevappa Mahesh. Mahesh is a very good friend of mine. Because of constraint of time, I can just say a few words about him. Currently, he is professor of radiology and radiological science at the Johns Hopkins University School of Medicine. He's a chief physicist in the same hospital, Johns Hopkins Hospital, Maryland, Baltimore, Maryland. He has written an exhaustive textbook on CT physics. I know I have seen his book, very elaborative, very informative, and he's a very talented person. I know him. He is a fellow of AAPM, fellow of CCPM, ACR, and so many. I mean, he is associated with many committees, NCRP and IEA programs. He is treasurer of American Association of Physicists in Medicine. So without wasting my time, I would invite Mahesh to please start a lecture on CT dosimetry. Thank you.
Thank you, Anil. Thank you, Ajay, and thank you for the organizer for inviting me. I see Professor G.S. Pant is here. We had worked together in the past. And so it's my privilege to talk about CT dosimetry and optimization. Here are my disclosures. Let me start with this one. I'm going to talk on the following topics. What is the CT utilization? And how are CT doses measured? And what are the CT dose descriptors? Finally, I'm going to talk about how medical physicists can help the clinic in optimizing the CT protocols. So to start with, I just want to show you the number of CT procedures done in the US, for example, is as follows. It has been growing consistently from past 20 years. I just want to say one of the landmark is 1998. That's when the multi-detector CT became commercially available. And from then onwards, we have seen the utilization of CT growing almost linearly 10 to 15%. It has grown not only in the hospital, even in the non-hospital settings, such as imaging centers. And it has grown quite consistently. And as of 2017, it's about 74 million procedures. Why is this important? Because after multi-detector CT became available, the role of medical physicists has been increasing even more with the proliferation of the CT scanners. And a lot of new applications opened up, such as hybrid imaging, PET-CT and SPECT-CT became commercially available after the invention of arrival of multi-detector CT. So is the CT perfusion, dual energy CTs, and also cardiac CT, all became as a new field and now matured field now, only with the background of multi-detector CT. And we also have seen the evolving role of medical physicists increasingly in understanding some of the CT dosimetry and performing dosimetry for patients and also for the machine itself. Also shown here is, it's not only in the US, the amount of number of CT scanners or CT exams done has increased across the world because of the benefits it shows. And you can see here the data from OECD health statistics in 2019. You can see the average is about OECD 35 countries. It shows the number of CT scanners and the MRI scanners in different countries. And I know in India, that's the number of CT scanners have increased the past 20 years. Quite common to see CT scanners even in a very small cities now. And because of the benefits the CT imaging is producing. Now, let me talk about the actual CT dosimetry. So I'm going to talk about the fundamental physics behind it. Just as a disclaimer, when we say CT dose is measured, we do not actually measure anything with the patient. It is indirectly measured using standard phantoms. And these phantoms are materials that mimic human tissues. There are, I know many of you are practicing a diagnostic physicist who are involved in the dosimetry, so you are familiar with these phantoms. And these phantoms are used for measuring CT dose. And from these measurements, you can estimate a patient dose. So how does one go about in doing CT dosimetry? So if let's say we are doing a 10 millimeter slice acquisition on a CT, ideally the radiation delivered should be only to the image volume like a square box. But in reality, it's more like this, which is more like a bell-shaped. Its distribution across the image volume. There is some distribution to the adjacent tissues also, because that's the tail of the dose distribution. So if you're doing a dosimetry, we need to make sure that we are taking into account this part of the radiation measurement also, because we can't simply measure the radiation dose in this area. Thus will be undermining or under-reporting the dose. Because of that, there's a concept called CTDI was developed back in 1974 at the US FDA, and it's called as the computed tomography dose index. It's just an index, and it's expressed in milligray. That's the unit of dose. And it basically telling us like it calculates the area under this curve, basically it's showing the dose distribution, and it divides by the number of slices, and usually it's expected to acquire about 7 slices to have a length almost 7 times the length on either side of the area which is acquiring the dose, to capture all the tail part of this particular radiation dose. In reality, what we do as a physicist, many of you know, we use CTDI using the standard phantoms. And these standard phantoms have been, fortunately, have been standards from the time CT were developed from 1974 onwards. The large one is called a body phantom, and we use a pencil chamber. A typical pencil chamber is about 100 millimeters length, and that's why we call the CTDI 100 as the computed tomography dose index 100 is basically indicating the length of the chamber. And this is given by this formula, basically integrating the dose on either side of the slice obtained in this particular phantom. The phantom is about 100 millimeter, 100 millimeter long, 10 centimeters length. These are the standard phantoms used for CT dosimetry. The large one is called the body phantom. It's a 32 centimeter diameter. And a small one is called a head phantom, also called as a 16 centimeter diameter. Sometimes we also have a pediatric phantom, which is a 10 centimeter phantom. But typically the body and the head phantom has been the standard one used for a lot of the dose display on the scanner. Typical dose distribution in CT varies by the size of the object. So if the object is small, the surface dose is almost same as the center dose. If the object is large, such as a body phantom or a body abdominal area of a patient, the center dose is almost half of the surface dose. So this understanding is very important when we are doing dosimetry, because we can't just simply measure dose on the surface without ignoring the dose at the center. In radiograph or fluoroscopy, the surface dose is the highest one, then it is decreasing. Whereas here, the surface dose is uniform as we are acquiring the data around the patient, and it's half at the center. And this concept is included in the calculation of computed tomography dose index. And we introduced, there's a new term called the second term abbreviation is called CTDI weighted. That's called the computed weighted average computed tomography dose index. And that's given as the formula. It's a 2/3 of the value measured at the edge of the phantom and 1/3 of the value measured at the center of the phantom. Again, the way the dosimetry is done is by placing the phantom at the center of the CT gantry and doing one single slice, an axial slice on the center of the gantry, and using a 100mm chamber, trying to capture all the radiation of the tails, everything, and then measuring at the edges, we can estimate what is called a CTDI weighted. The next thing is, most of the CT scan now are done in a helical scan. When we do helical scan, a concept of pitch is introduced. And the pitch is introduced as the table feed per rotation divided by the actual beam width. In a multi-detector CT, the beam width is actually the product of the number of channels used times the thickness of each channel. Let's say it's a 64 slice CT scanner. In that case, if you're acquiring 64 by 0.5, and that will be here, the weighted value, N30. The reason why pitch becomes important is we need to incorporate into the CTDI calculation, and we have the term called as estimated average patient dose as called the CTDI volume, and that's given as the formula, the CTDI weighted divided by the pitch. So basically the pitch is incorporated into this particular measurement, so to get what is called as the descriptor called CTDI volume. And this is the descriptor, which is one of the key dose descriptor in CT. Why the pitch is important? Because here is a situation showing the radiation dose in a patient varies with pitch, because if the pitch is 1, which means you are acquiring the data without any anatomical gap by placing one slice after the other. For example, it's like a slinky. If you have a slinkies all together, there is no gap, that's equal to pitch of 1. But if the pitch is greater than 1, that's the scenario here. You're acquiring the scans, acquire the patient quite fast, whereas you leave some gaps in between. And that's a pitch greater than 1, which implies extended imaging and reduced patient dose. Also, it has some lower axial resolution. A pitch less than 1 implies overlapping and higher patient dose with higher axial resolution. A pitch less than 1 means you're scanning the same region with lot of tissue overlap, and that can translate to higher dose. Because the radiation dose to the patient is given as inversely proportional to the pitch value times the MAS rotation. So that's one of the reasons why the pitch is incorporated into the CTDI value. Here are some common disclaimer or the standard information about the CTDI 100 and CTDI volume. The CTDI 100 is because it's measured with a 100mm ion chamber, and that's standardized across the globe. So if any measurement is given as 100, we know that they use the same phantom, and this is the ion chamber was used, a calibrated ion chamber. From there, we arrive at the CTDI volume, which is calculated, and it is not measured directly. Then it's measured from a single axial acquisition, but calculated with a pitch value. For a medical physicist working in a clinic, one of the important role is acceptance testing. When a new scanners arrive, we do a lot of acceptance testing to verify whether the scanner output is as it's supposed to be. For that one, we can take a lot of advantage by using the technical specification of the manufacturer, because the manufacturers provides these type of a dose tables, which they have done in the factory, and displays the dose for different locations and different composition. And one of the primary aspects of a medical physicist is to, to mimic this measurement and make sure that the techniques are similar to what they are getting. That will tell you the scanner output is same as indicated. Having said that, when you're talking about the patient dose, we are not confined to doing only one single slice. We do a number of slices, and that's incorporated into this concept called as dose length product, also called as DLP. So the DLP is basically a summation, is a product of the CTDA volume multiplied by the scan length. And this particular DLP is important because that will show us the total energy imparted to the body. And that is can be used for estimating the risk. And that's why the DLP becomes very important. There are two scenarios here. If all the same techniques are used, if the techniques are same between two patients, then the CTDA volume in these two cases will be the same, 2 milligray. The first case has 10 slices of 1 centimeter, and the second one has a 20 slices of 1 centimeter. So therefore, because of the scan length, the DLP in the second case is twice that of the first case. And that's important for understanding of the biological risk estimation and so forth. So in comparison, what we do here is like CTDA 100 is what we measure, and we calculate CTDA weighted, and you take into account the pitch value that's called the CTDA volume. You multiply that by the scan length, we get dose length product. From here, we do a lot of estimation to arrive at the effective dose. Therefore, as of now, the key dose descriptors in CT are these two. Computed tomography dose index, measured indicated as CTDA volume, expressed in milligray, and the dose length product, DLP, expressed in milligray centimeter. When a patient asks what is my dose, they typically mean what is my risk. They are worried about this radiation, what's going to cost for me, and so forth. So they don't want a physicist to give a bunch of numbers. They want like, what is my risk? One way to calculate the risk is by deriving it what is called as effective dose value. Because the effective dose estimation is a single dose parameters which reflects the risk of a non-uniform exposure in terms of the whole body exposure. It provides way to compare risk with other radiation exposure. For example, when any of the radiation exposure is expressed in terms of effective dose, such as the natural annual background radiation or cosmic radiation or nuclear medicine procedures or a X-ray procedure, they all can be compared on a same playing ground when we express in terms of effective dose for comparing the risk. So how does one calculate the effective dose? Shown here is the CT and the risk chart, basically showing this how the measurements are done in the phantom, and then you're done in the CTDI doses in phantom per slice. You take into account the length and the pitch, we get the DLP. From there, we can calculate the effective dose. And the effective dose, we can derive some sort of a risk estimation. There are a variety of ways to calculate the effective dose. One can use the Monte Carlo simulation, with based computer software to calculate the effective dose. One can also calculate the organ doses and then calculate the effective dose. And there is some controversy with respect to use of effective dose on the patient, but we continue to use that in the absence of any other methodology. Also, for an easy purposes, there is also a published factors called as a K factors are published. These are based on the K and DLP. And one can use the K factor and multiply the DLP to get what is called as an effective dose. This is one example showing the effective dose estimation using a impact CT dose calculators. This calculator basically shows the anthropomorphic phantom, human phantom with the determined with the geometric shapes of the organs, and the program can select the type of scanner and which has a built-in value, so automatically it will calculate the effective dose values for different organs, and the total values also here. Here are the effective dose. These are the standard K factors published as of now, and we continue to use these K factors still, because even though there is some limitations on the K factor, because these were developed for the scanner prior to the multi-detector CT, but we still use for easy comparison. So basically, you take the DLP from this patient, and if you multiply by this K factor, you arrive at an effective dose, an approximate effective dose. For example, shown here is the radiation dose report on a CT angiography procedure. For example, here, it shows the patient had a calcium scoring, test bolus, and a coronary CTA. And the scanner puts out KVP, what was used, and also the DLP of the particular scan. And a physicist can take these values and determine with the K factor to get at an effective dose value. Here are some effective dose values for the CT exams. Showing here are different type of CT exams. And these are the effective dose using the ICRP 60. And here is the effective dose using ICRP 103. Because the ICRP 103 has changed the weighting factor for breast tissue and also abdominal tissue. And that has to be taken account if we are doing the calculation. Philosophically, that's one of the reasons why physicists do not want effective dose values to be given. Rather, just give us the DLP and the CTDI and the DLP as the key dose descriptor, because the effective dose can change depending on the weighting factors. And this happened in the last 10 years, where historically we are using the ICRP 60 weighting factor. With the new ICRP 103, the values change. And it becomes quite confusing for a patient if it is not explained properly. That's why having the DLP value will help the medical physicist to calculate the effective dose values and estimate the risk to the patient. So here, for example, the PET CT, for a whole body PET CT is about 10 millisievert, and for a cardiac CT is about 8 to 9 millisievert, and so forth. Now, let me talk to the latter part of my lecture called the CT dose optimization strategy. In order for us to provide some idea for a CT dose strategies, we need to understand the scan parameters, the CT scan parameters, and we also need to understand the different things called as tube current modulation. I'm going to talk about tube current modulation, voltage variation, and iterative reconstruction only. Because there are other optimization strategy, but I consider these three are very important one. Let's look at here at the scan parameters. Here is the one slide showing the scan parameters, which has an impact on the radiation dose and image quality in CT. I like to group into three different buckets called as the primary factors, secondary factors, and other factors. For the primary factors, for a physicist or a radiologist, it's important to understand these factors, such as what is the implication of the tube current? What is the implication of the tube voltage? The patient dose directly varies as tube current. With respect to tube voltage, the patient dose varies as kV square. And the scan time, pitch, and acquisition time, especially the scan acquisition type, is important when we are doing a cardiac CT. The secondary factors impact on the image quality, but not so on the direct, because it's already acquired data. So let me talk about CT dose modulation. With the arrival of this CT and the concern about the radiation dose, what we have here is like, so we have here two things. In general, what we have is called the X-ray attenuation is lower in the AP direction and higher in the lateral direction. However, generally, without modulation, the CT scanner uses the same tube current, acquiring the data around the patient. So this particular principle, this particular aspect is exploited by changing the tube current. while traversing around the thin portion of the body compared to the thick portion of the body. And when you talk about dose modulation, there are two types of dose modulation. One is called the spatial dose modulation. The other one is called the temporal dose modulation. I'm not going to talk much about the temporal dose modulation, and that's focused towards cardiac CT. But in general, 90% of the time when we say dose modulation, it implies spatial dose modulation. What is spatial dose modulation? It is modulating or changing the tube current based on the patient thickness at different spatial projections. And this is utilized in most body protocols. The temporal modulation is based on modulating tube current at specified time points of an ECG signal, and I'm not going to discuss much about it. So here is an example. Here is shown is the spatial dose modulation. On this shown here is a chest CT, the MA used for a chest CT. As you can see here, the tube current was very high around the neck area, the shoulder area, because the scanner determines the thickness is quite thick in the shoulder area. Therefore, it is pushing out more tube current to create the same image quality. But the scanner then determines around the chest area, it doesn't require the same amount of tube current. Therefore, the tube current decreases. And this is the principle, general principle used by the various CT manufacturers. And this is called the tube current variation based on spatial variation. However, I want to draw your attention is, as a medical physicist, it's important for us to understand the various manufacturers does this particular modulation slightly differently. They are not do the same way. And that becomes very important, because if we are helping a clinic to understand the dose modulation, we need to understand what that particular manufacturers employs the dose modulation in a way. There are some caveats and limitations of the automatic exposure control or the tube modulation. If the patient has a prosthesis or a metal implant, that can artificially increase the patient dose because the scanner sees the thickness and it automatically drives the
Kindly mute your audio. Sorry, Professor.
Audio. Thank you. For a very low dose CT protocols, also the manual selection becomes more important. So when we're doing this, when we're getting this dose report, the CTTA volume, if the protocol uses the automatic exposure or the tube modulation, the CTTA volume reported is an average value of all the slices, and it gives out as an average value based on the average tube current used throughout the scan. And essentially, the CTTA volume depends on the KV, the bow tie collimation, rotation time, and then average MA. Shown here is the display of the CTDI even before the scans are done. So this is called a pre-scan display of the CT dose. As you can see here, where the technologies are setting up the technique, the scanners are now required to report the CTDI volume value, and most of the scanners also tells which particular phantom it is based on, because the manufacturers have built-in table for all these different kV settings and conversion factor. So automatically, if you change any one of the parameters, this will actually be reflected here. If you're doing a scan with a dose modulation, the final reports looks like more like this one. It tells like it is 164 MAS based on a reference MAS of 150. What it means is like each scanner has a built-in curves for utilizing the tube current based on the patient thickness within certain desired value, desired range, and that's what this is showing around. Dose modulation has been very effective. In fact, it is now almost, it's a requirement to make sure that all the CT scan we do has a dose modulation turned on, because you can turn off and on, because without doing nothing, the scanner will automatically determine the dose required and reduces the dose to quite a considerable amount of value. The other aspect when you're doing dose modulation is it's important that the patient is centered exactly in the center of the gantry. If not, that can incorrectly give more dose to the patient depending on the position. Because the scanner to a topogram or a surview, well, when it does that, use that as a reference picture to do all the changes. For example, here if the patient is positioned incorrectly, the radiograph looks like large. Therefore, when you're doing an acquisition, it will deliver higher doses to the patient. Similarly here, therefore, putting the patient in the isocenter becomes very critical for the proper functioning of the tube current modulation. The second optimization feature is the tube potential selection. And it's important because if you change the tube voltage or decrease tube voltage can significantly reduce dose, which is typically kV square. And as you can see here, from 120 kV, if you go to 100 kV, the effective dose for a particular scan goes from 1.6 millisievert to 1 millisievert. And that is exploited to a large extent. The other thing which I want to draw your attention is there are certain advantage to use low voltage and thin patient and also pediatric patient, because for those scans using contrast, if we change the tube voltage from 120 to 100, for a small patient, the contrast will actually increase, means the image quality contrast higher. At the same time, if we look at the radiation dose normalized to 120 kV, the actual the radiation dose decreases. Because of this, there are two advantages: the increase in the image quality and the decrease in the radiation dose if we use a lower tube voltage compared to historically used 120 kVp. Shown here is an example of the effective dose estimation between 100 kV and 120 kV in a cardiac CT, showing no difference in the image quality. Pardon, there's some grass mowing around in the neighborhood, so that's why this noise is. Please apologize. And here is the effective dose estimation. It is also important if the clinic is doing CT perfusion, where the CT perfusion part has to be done at a lower kVp at 80 kV. Otherwise, the radiation dose can be really high, leading to hair loss or skin burns. So it's important that the protocols are done at a lower kV. Iterative reconstruction has helped a lot, because it is the objective is to enable user to acquire data at a low dose and improve image quality with the iterative process. And most iterative reconstruction algorithm is due to manufacturer's property known as a black box. So what's shown here is like, here's the standard reconstruction method abdominal image. The same thing done with a iterative reconstruction, it can actually decrease the noise to some extent. And that's why the iterative reconstructions are used, because you can acquire the image at a lower dose where the image is quite noisier. You increase the image quality by using iterative reconstruction. But iterative reconstruction has to be used in a very cautious way, because if you do extreme correction, the image can really look very opaque or even introduce some artifacts which can mimic low contrast objects. Here's an example of iterative reconstruction done at full dose and half dose. See the image quality, there's now some noise. When this is mixed with the noise, denoising CT images, you can actually high dose, it can actually decreases the image noise in the background, thereby increase the image quality. So here are some of the acquisition parameter settings summary. I'm sorry, there's the noise in the background. Please apply. Please pardon this noise. These are the acquisition parameter settings summaries for the CT. The scan modes and the relationship with respect to CTDA volume is shown in this particular graph. For example, the pitch, the CTDA volume is inversely proportional pitch. Tube voltage, the CTDA volume increase proportional to kV square, which is go to 2 to 3. It's usually 2. Tube current is product is basically directly proportional to CTDA volume. So this particular parameter is showing the relationship with respect to CTDA volume in this particular case. The other optimization strategy is very straightforward, is to decrease the scan range to the only area when you require. And that actually, instead of having the entire abdominal pelvic area, if it is not required, you can actually do only the abdominal area and minimize the area of the unnecessary scan. So, for example, here, this is the correct range for the abdomen and pelvic scan, whereas this one, there's no need for exposing the chest area compared to this one. So these are all the strategies which is used. So in summary, the benefits of the CT studies far outweighs the radiation risk, as long as the appropriateness is justified. One of the important thing is we need to understand and also implement all the dose optimization strategies utilized to enable radiation dose. Let me stop here. I'll take any questions.
Thank you, Mahesh. Am I audible?
Yes, very much.
Yeah. Okay.
Yes.
Thank you, Mahesh, for your very excellent lecture on CT dosimetry and dose optimization in CT. We are very thankful to you for joining us with a very short time, and your lecture was really very excellent, very informative. There are a few questions. Number one is, what Monte Carlo code can be used to compute effective dose?
Oh, there are variety of Monte Carlo simulations which I'm not involved directly, so I'm not sure Janet and other Monte Carlo simulations are available. And so I do not know, I cannot give an example of exactly which one to use.
Okay. Second question, Dr. Kinkar and Dr. Morgan asked about dual energy CT scanner. What is the dose, difference between single energy and dual energy in terms of dose optimization and doses?
So the dual energy CTs are done almost with the same doses as a single energy scan, because we are adjusting the MAS for different AV setting, and that has been shown that the dual energy CT doses are similar to a single energy CT scan for cardiac or abdominal and other things. Because initially, when we introduced dual energy CT, it was slightly higher, but now we see we are able to do dual energy CT almost the same dose as a single energy CT scans.
And another question is, typical CT dose in 4D CT phase-based and amplitude-based acquisition.
Okay, that is with respect to the radiation therapy when you do this 4D CT for lung simulations and everything. And it's very difficult to tell how much because it varies on the number of acquisition and number of scans they are doing. So there are some literature published values which varies on the type of CT or 4D CT you're acquiring.
Okay, Mahesh, this is my question. See, CTDI 100, okay, CTDI 100, volume, etc. They are valid only for 10 centimeter length, Z-axis, right? Now, current CT scanners are using more than this. So, is still CTDI valid in that case?
It is still valid. There is some limit. There is a limitation on this one. So what we do some corrections for this one. There are studies shown that we have also shown using using a 300 millimeter chamber versus a 100 millimeter chamber with 3 different phantoms, and we can get a little bit more accurate. But there are some correction factors, because imagine physicists carrying all the 3 phantoms for doing the measurement. Rather, you can use the same 100 millimeters chamber, and you can actually incorporate this collection. ACR has put out a formulation, how we calculate, and that still there is some underestimation, but it's still within the range margin of error. Otherwise, to be very accurate, you can calculate with 3 phantoms, but even then, the difference between is much lesser.
I'm sorry for the short of time. We can't take more questions. So now I must thankful to you,
Thank you
for giving us, you are instrumental in organizing International Scientific Exchange Program twice in Delhi, and Dr. Pant and myself really thankful to you. And he has just asked me to thank you especially. So now I'm handling this to Dr. Shobha. Dr. Shobha, please.
Thank you for the organization, inviting me to this meeting. Thank you.
Thank you, Professor Mahesh, for an excellent talk. Thank you, Dr. Ajay Srivastava. We now come to the last part of the program, which is the concluding remarks and vote of thanks. I now invite Dr. Prateek Kumar, Vice President, AMPI, to give the concluding remarks and vote of thanks. Dr. Prateek.
Thank you, Madam Shobha. AMPI, Association of Medical Physicists of India, has organized this IDMP, International Day of Medical Physics. And earlier there was some plan for making it a 1 week celebration, but due to pandemic, I think everybody had cut short this whole celebration. So AMPI was able to celebrate this with the help of international faculties, as well as a overwhelming presence of the AMPI members in this IDMP celebration. I must thank Professor Anatoly Rosenfeld from Australia, who must be the very late night, still giving time to us, as well as Dr. Mahesh, who must be very early morning in USA. So these two extremes we have to meet with the whole Indian scenario. So Professor Anatoly Rosenfeld has a very well explained some novel dosimeters and which can measure the doses and which could be at the same time could be very beneficial for the interventional radiology to the small field dosimetry. And that's why it was a very good talk. And his was the only CAMPEP accredited program in in this eastern part, I will say, Australia, Asian, not Asian region, but Australia. This is the only CAMPEP accredited program he runs. He's the director and founder of CMRP, Center for Medical Radiation Physics. So he has already invited all of MP members that if we can collaborate with him in this newer coming field, that will be very good for MP as well. So there is a lot of collaboration, potential of collaboration. So I thank him with my folded hands. Dr. Mahesh is always friends to MP and has been a constant feature for our annual conference. Again, this is my pleasure that just I am proposing vote of thanks that he has given his time and expertise to this area, and he is a known name in the city dosimetry and city regarding this, and we look forward for further collaboration in this area. Diagnostic medical physics still has to be picked up in India. Now slowly it is picking up, but pace is slow, and I do look forward to you and to other people who are working in diagnostic medical physics all over the world, that how we can collaborate further. Dr. D. Devkumar has given very nice talk on the radiomics, which is now picking up. And probably this is the area, radiomics and the same machine learning, this area where really medical physics has to come up to the level. Since now this is going to be future. In imaging, it has already come, and in radiotherapy, it is slowly gaining the ground. Probably that is the area where we have to educate ourselves as well. We have to include the formal education to the medical physics training, basically. So I again thank Dr. D. Kumar, who has done a very excellent job in presenting. And last but not the least, our participants who were around 100 in this whole conferences. I thank them that they have very patiently and very actively they participated in this deliberation. I thank all of them. Thank you very much. So now to President.
Thank you. So I take this opportunity to thank both the speakers from abroad, especially Dr. Anatoly Rosenfeld and Dr. Mahesh. Even I am disturbing by sleeping by sending a WhatsApp today morning. So sorry, sir, for this because this time difference. So, and we will love to have you whenever we have any such opportunity, and we feel you are our homely person, and we have right to call you whenever we want. So thank you very much once again. Have a nice day, and we will look forward to meeting you once again for such occasions. Thank you very much. And thanks to whole team for organizing this program and celebrating this IDMP. Thank you very much.
Thank you.
Thank you all.
Thank you.
Thank you.